Proceeding into the complication, we must know some important definitions that are frequently used in the liver disease discussion. The first is, what is chronic liver disease? It is a progressive destruction of the liver parenchyma over a period of greater than 6 months that is leading to the fibrosis and the cirrhosis. Compensated cirrhosis, it is an asymptomatic stage in which the patient do not have ascites, variceal hemorrhage, hepatic encephalopathy, or the jaundice. That it means it is the early stage. In decompensated cirrhosis, it is an acute deterioration in the liver function in a patient with cirrhosis and characterized by the jaundice, ascites, hepatic encephalopathy, hepatorenal syndrome, or variceal hemorrhage. So, discussing the decompensating event or the complication of the decompensation, ascites is being the most common decompensating event in the liver disease. Spontaneous bacterial peritonitis, variceal bleeding, encephalopathy, hepatorenal syndrome, and hepatocellular carcinoma. So, we will discuss these complications of the decompensation in the today's lecture. Now, what are the varices? Basically, varices are the dilated veins that develop secondary to the portal hypertension. It can occur in any part of the body where there is portosystemic anastomosis. Basically, how the varices develop is the concept of development of the varices is like this. Whenever the liver is cirrhosed, there is resistance to the blood flow from the liver. So, the blood that is entering into the liver feels resistance in its flow. So, where there is the portosystemic anastomosis, blood divert to that side. So, when the blood flow increases in that anastomotic sites that are not the usual sites, pressure increase in their size enlarge and they become the varices. The commonest location which can cause bleeding are the esophagus. Esophageal varices are the most common source of the bleeding, and esophageal varices are the most common location of development of the varices. Then the other point is the stomach, then duodenum, rectum. So these are the places where the varices commonly develop, but it can develop at any site where there is the portosystemic anastomosis. That is the flow of the blood diverts from the portal circulation to the systemic circulation, bypassing the liver. Patient normally present with the hematemesis, that is the blood in the vomitus, melena, that is the black colored stools, bleeding PR. But the patient can present with the anemia. There is small micro leakage of the blood through the varices, and which may not be obvious in the form of the hematemesis and the melena, but patient can lose a small amount of the blood through these varices and can present in the form of the anemia. How we manage the patients with the variceal bleed? It basically, whenever we are managing patients with any emergency, with any disease, we divide into some general measure and some specific measure. In general measure, we start with the resuscitation. As you all know that variceal bleeding is an emergency. Patient can present in any form, like in the stable condition, or in unstable condition, or in the form of the shock. So resuscitation is the first step in the management of patient with the variceal bleeding. Maintain the airway, breathing, oxygen, attach oxygen if the patient is hypoxic, get some urgent blood test done, which includes full blood count, urea and electrolyte, LFTs, clotting screen, cross match of the blood for arrangement of the transfusion products, and ABGs. We normally pass a double large bore IV cannula. We need large bore cannulas because we need to give fluid in the huge amount. We need the large bore cannula to give maximum boluses. We need to transfuse the blood. So in the large bore cannula, we can give the large amount of the replacement fluid, and there is small chances of the blockage. Fluid resuscitation is very important. Arrange the monitoring setup bed, HDU or ICU for the patient. Vitals and urine output monitoring. In the vitals monitoring, basically we monitor the tachycardia, we monitor the blood pressure, we monitor for the postural drop. If the it gives a clue about the status of the patient and the status of the bleeding status. Like if the patient is tachycardic or hypotensive, or if there is a postural drop, then it means that there is active bleeding and patient is in unstable condition. So we need to stabilize the patient first by supportive measures and then proceed for the further management. Correct anemia and the coagulopathy. Basically, if there is anemia, we need to blood transfuse the blood products. If there is coagulopathy, we should correct that before any specific procedure. Transfusion trigger should be set. There is a debate about there was a debate about the restrictive and aggressive transfusion strategy. Our transfusion aim should be if the hemoglobin is less than 7, then we do transfusion. Otherwise, if the hemoglobin is above 7, then we can wait, because whenever we transfuse, we over transfuse the patient. Basically, transfusion increases the blood volume and it increases the blood pressure in the vessels. So when the patient is bleeding, if we increase the pressure in the blood, increase the volume, it increases the chances of the bleeding. So our transfusion strategy should be based on the aim of hemoglobin between 7 to 8. And then the antibiotic. Why we give antibiotic in patient with the upper GI bleed? Basically, when the vessel is ruptured, there is an O, and it can be a portal of entry for the bacteria from the gut to the vessel. And if the bacteria is entered into the from the gut into the blood vessel, it circulates into the body and it can cause the septicemia. So antibiotic prophylaxis is necessary in patient with the variceal upper GI bleeding. Now the specific measure. Specific measure includes drug and endoscopy. In drugs, we used to give the terlipressin, that is the vasopressin analog. And what terlipressin do? Basically, in the cirrhosis, there is the splanchnic vasodilation. What is splanchnic vasodilation? Basically, that is the supply to the viscera and to the organs is called splanchnic circulation. So there is splanchnic vasodilation. The terlipressin basically acts as a vasoconstrictive agent. It vasoconstricts the vessels and therefore decreasing the supply to the portal circulation. It's contraindicated in the shock and the perivascular disease, the peripheral vascular disease. Somatostatin is another agent, that is a somatostatin analog. It can also be used second line agent. Endoscopy is the most specific treatment in the patient with variceal upper GI bleeding, and it should be done after stabilization within the 24 hours. As we have discussed in the previous slide, that stabilization and resuscitation is the most important step. Endoscopy is although the most specific treatment, but we have to stabilize the patient first and then proceed for the endoscopy. What options do we have in the endoscopy? Basically, in endoscopy, we do the band ligation. This is the first choice of treatment for the esophageal varices. Whenever we do the endoscopy and we found that there are the esophageal varices, so our treatment option would be the band ligation. Another option is the sclerotherapy. Basically, what we do in the sclerotherapy and when we do the sclerotherapy. When there is uncontrolled bleeding and we cannot find any source of the bleeding in the esophagus, or the esophagus is filled with the blood and the clots, and that is minimizing over the region. So we randomly inject an agent that sclerosis the vessels. So this is called sclerotherapy, and its complications include transient fever, dysphagia, chest pain, ulceration, and the strictures. The third option that we have in the upper GI endoscopy is variceal obturation with the glue. This procedure is normally called fundal varix obliteration. It is particularly good for the gastric and the gastroesophageal variceal bleeding. Band ligation was for the esophageal varices, and fundal varix obliteration or variceal obturation with the glue is for the gastric varices. And in this procedure, we inject an sclerosing agent into the gastric varices, and there is a risk of embolization to the lung, spleen, or the brain, or any vessel. Another option is transjugular intrahepatic portosystemic shunt. It is done where bleeding is not controlled by the endoscope. patient came to you, you did an endoscopy, but you cannot control the bleeding, and then you proceed for the translunar intrahepatic portosystemic shunt. Basically, what we do in the translunar portosystemic shunt, we use an anastomosis between the portal vein and the hepatic vein. Basically, we communicate a channel. Portal vein is carrying blood from the viscera to the liver, and hepatic vein is carrying blood from the liver to the heart. So the problem is basically into the liver. There is increased resistance that is increasing the backflow and the portal pressure. So we lay a channel from the portal vein to the hepatic vein. So blood bypassing the liver. The blood that is initially going through the liver, now after this shunt, that is traversing directly from the portal vein to the hepatic vein, so bypassing the liver. So hepatic vein is cannulated percutaneously through the internal jugular vein using a needle under ultrasound guidance, and a track is created through the liver from hepatic to the portal vein, and it causes reduction in the portal pressure. There is high success rate, but encephalopathy found in 25% of the cases. As I told you that why encephalopathy increase in these patients, as liver is the detoxification organ of the body. When the blood is bypassing the liver, that is by after the steps, that is traversing directly from the portal vein to the hepatic vein. So detoxification cannot be done of these patients because blood is not passing through the liver, it is bypassing the liver. So as a result, toxins and the other things increase in the blood that depresses the brain and causing encephalopathy. But its success rate is very high in patients with the upper GI and it reduces the portal pressure significantly. Once you have done with the acute management, you control the bleeding of the patient and you stabilize the patient, and patient is ready to go home. Then you give something for the prevention of the variceal bleeding for the further future episodes. So beta blockers are the mainstay. These lower the portal pressure and risk of further bleeding by reducing portal blood flow. Nitrates are another option. Endoscopic screening is another option. Now, what is the endoscopic screening? When we do the endoscopy, we found the varices, we band them, and it doesn't mean that the varices cannot develop in the future. Because there is a problem, it is a symptomatic treatment. Problem persists with the cirrhosis. So again, the varices develop. When the varices develop, they again increase the risk of the bleeding. So endoscopic screening is the further endoscopies that is being done after the initial endoscopy, and there is a protocol for the endoscopic screening. We do if there are the large varices, we do after every 2 to 4 weeks, and if there are the medium varices, then we do after 3 to 6 months, and then if there are the small varices in the early endoscopy, then we do after 1 year, and repeatedly with the same session. Ascites is the next complication of the decompensation. That is, it is the accumulation of a fluid in the peritoneal cavity that is causing abdominal swelling. Cirrhosis is being the most common cause of the ascites, accounting for the 75% of the cases. Malignancies, heart failure, TB, renal failure. These are the common causes, but renal failure and the malabsorption can also cause the development of the ascites. How to investigate the patient with ascites? In this, we need to get some blood tests, some imaging, and some tests for the ascitic fluid. In the blood test, we do the CBC, in which we can find anemia and the platelet. We can get clue about the liver disease. If platelets are low, then it can be liver disease. Urea and electrolyte, it gives clue about the renal disease, some renal disease, and LFTs. Clotting screen is necessary for both. We plan for the ascite. In the future, we plan for the ascitic tap. Clotting should be normal for the ascitic tap. In imaging, we do the abdominal ultrasound. It can show us the liver mets and liver cancer cells. Hepatic vein arterial Doppler can show the thrombotic events in these vessels. Splenomegaly, that is the sign of the portal hypertension. Chest X-ray may show the pleural effusion or the sign of the heart failure. So we can get a clue regarding the ascites may be due to the heart or due to the, some lung pathology like the just hold for a minute. Basically, I'm not getting my the screen. Uh, just hold on for a second. See, for this slides on the on. Sorry for the interruption. Ascitic type, it is the diagnostic parameters and this is the standard investigation of the ascites. Whenever there is a fluid in the body at any place, like in the pleural space or in the peritoneal space, it needs to be tested. It needs to be tapped, it needs to be tested. This is the gold standard. And the ascitic fluid should be sent for the measurement of albumin and protein, neutrophil count, amylase, culture and sensitivity, and cytology where malignancy is suspected. So whether this ascitic fluid is transudate or exudate, we decide it on the basis of the serum ascites and albumin gradient. It's called SAG. So how we calculate SAG? It is being calculated by subtracting serum albumin, ascitic albumin from the serum albumin. If, like example, if the serum albumin is 3.6 and ascitic fluid albumin is 0.6, then we subtract ascitic albumin from the serum albumin, that is subtracting 0.6 from the 3.6, then it is 3. So if this reading is low, that is less than 1.1, then the cause of the ascites is non-portal hypertension when it is exudate. And if reading is more than 1.1 or high, then the cause of the ascites will be portal hypertension, that is fluid leaking into the peritoneum. So basically, this SAG divides. SAG basically tells us whether the ascites is due to the portal or non-portal. Management includes drug and non-drug. Non-drug, the mainstay is the salt restriction. That is, you restrict the salt to the 4 to 60 grams per day, and you tell the patient that you cannot use any added salt. Whenever the patient is a salt intake and increases diabetes. In drugs, the mainstay are the diuretic. Spironolactone is the drug of choice. and it is used at a higher doses than for the heart failure. In heart failure, we use the lower doses of the spironolactone. Start with the 50 to 100 milligram and can go up to 400 milligram per day. So how we judge that this dose is sufficient or not? Basically, we monitor the weight, and we aim for the weight loss of 0.5 to 1 kg per day initially on patients with the diabetes. 0.5 for those patients who do not have edema like pedal swelling or facial swelling, and 1 kg in those patients who are having edema associated with ascites. Loop diuretics may be used as an adjunct to the spironolactone. Another option is the hepatic paracentesis. In patients with the diuretic refractory ascites or who are intolerant to the diuretic should go regular large volume paracentesis. Paracentesis is basically the removal of the fluid from the peritoneal cavity. So we pass a cannula into the peritoneal cavity and remove excessive fluid from there. Human albumin solution 20% should be given alongside all large volume paracentesis, so more than 5 liters is removed. Caution if the patient is miscalibrated, and ensure platelet count should be greater than 50 and the coagulation should be normal. Transjugular intrahepatic photosystemic shunt is another option. It can be used in patients with refractory ascites that is needing frequent paracentesis, which means greater than 3 times paracentesis per month. So rather than going for the repeated paracentesis, it can be option which can reduce the formation of the ascites. Spontaneous bacterial pattern, this is the infection of ascitic fluid in the absence of any intra-abdominal or surgically treatable source of infection. The organisms are usually E. coli, streptococci, and enterococci. Common presenting features are the abdominal pain, fever, nausea, vomiting, and decreased urine output. Patient can present the fever, abdominal pain. Whenever a cirrhotic patient with ascites comes with the fever and abdominal pain, think of that first. Rule out as first, and then other things. Investigation in suspected ascites, diagnostic paracentesis that is very necessary whenever there is a fluid, and then specifically when the patient presents with the abdominal pain and the fever, and it should be sent for the ascitic DR and ascitic CS. It is mandatory in all patients with cirrhosis requiring a hospital admission. Ascitic fluid contains greater than 250 cells per milliliter of the neutrophils. Like if you found more than 250 neutrophils in the ascitic fluid, then this is diagnostic of ascites. Regarding its treatment, from broad spectrum IV antibiotic, in which cefotaxime is the drug of choice. Any other broad spectrum antibiotic can be used. Treat as soon as the ascitic sample has been sent and with high index for suspicion. If the fluid resuscitation needed for the septic shock, then try to avoid colloid with fluid and use plasma scatters such as human albumin solution. Good evidence for prophylactic antibiotics after one episode of HBV. Like if a patient develops episode of HBV, then there is the good role of ciprofloxacin and norfloxacin as a prophylactic antibiotic for the prevention of further episodes. Another complication of the decompensated hepatorenal syndrome, this is occurrence of renal failure in patients with advanced liver disease in the absence of any identifiable cause of the renal failure. 10% of patients with cirrhosis and ascites. Labeling patient as a hepatorenal syndrome, it is important to rule out other causes of the renal injury because it is diagnosis of exclusion. If you cannot find any other source of the renal injury, then you label this patient as a hepatorenal syndrome. What are the other causes? Like if the patient is taking any nephrotoxic drug, if the patient is having diabetes or hypertensive, because chance of development of CKD like hypertension, nephropathy, and diabetic nephropathy. If basically we rule out all other causes, then we label it as hepatorenal syndrome. Its risk factors include unstable blood pressure, use of diuretics, acute alcoholic hepatitis, GI bleeding, spontaneous bacterial peritonitis, and other infections. These are the risk factors for development of hepatorenal syndrome. What is the pathogenesis of hepatorenal syndrome? Basic concept is renal insufficiency, which is leading to the renal failure. The renal vasoconstriction is the compensatory effect of renin-angiotensin system and ADA that is triggered by extreme underfilling of the arterial circulation. Now, how this underfilling of the arterial circulation develop in patient with cirrhosis? As I told you, there is splanchnic vasodilation in patient with the cirrhosis. Whole of the blood has been in the splanchnic circulation. So, whenever the whole of the blood is in the splanchnic circulation, renal circulation compromised. There is decreased circulation towards the kidneys. And when the circulation of the kidney is decreased, body has a compensatory effect. It releases ADH and it will activate the renin-angiotensin system, which is causing further renal vasoconstriction and causing the development of the hepatorenal syndrome. There are the two types of hepatorenal syndrome. Type 1 that is rapidly progressive and is triggered by an event such as LVP and requiring urgent intervention. This is basically needs aggressive management. Now in type 2, it occurs gradually, slowly as a consequence of aggravation of the end-stage disease. As the disease progresses, renal injury progresses with the liver disease. These are the parameters to be monitored. It includes urine output, fluid balance, arterial pressures, and standard vital signs. Screening for infection should be done as infections are a common cause of hepatorenal syndrome, and all diuretics should be stopped because diuretics can also cause renal injury. Treatment of hepatorenal syndrome includes plasma expanders, normally human albumin solutions. Terlipressin should be given at a dose of 0.5 to 2 milligram IV 4 times daily. Renal replacement therapy, which is normally called hemodialysis, and ultimate treatment is the liver transplant. Hepatic encephalopathy is a brain dysfunction caused by the liver insufficiency or the portal systemic shunt. It manifests as a wide spectrum of neurological or psychiatric abnormalities ranging from subclinical alteration to coma. Common precipitants are renal failure, GI bleeding, infections, constipation, sedative drugs, diuretic, and high protein intake. This is the best human criteria for the semi-quantitative grading of the mental status. Basically, hepatic encephalopathy has been divided into the 4 grades from grade 1 to grade 4. In grade 1, there is lack of awareness, impaired performance of the addition, and shortened attention span. In grade 2, there is lethargy, subtle personality changes, inappropriate behavior, and impaired performance of a subsection. And in grade 3, there is somnolence to semi-stupor, but responsible to verbal stimuli, confusion. And in grade 4, there is coma that is unresponsive to verbal or nauseous stimuli. So basically, grade 1 is the lower grade, and grade 4 is the higher grade. And the patient can present in any grade. It can progress from grade 1 to grade 4. And if we treat patient of the grade 4, we can revert back to the normal position. Investigations in the hepatic encephalopathy full septic screen, as the infections are the common source of hepatic encephalopathy, so we need to investigate regarding infection. UCs, that is urea creatinine electrolyte, ascitic tap to check for the SBP, DR is check for the fecal infection, and ammonia levels are raised and can help with the diagnosis. The sample needs to be collected and then stored on ice and sent directly to the laboratory. EGs are not so specific for the hepatic encephalopathy, but it can rule out other causes. MRI, CT can help to exclude other causes or alter mental functions such as intracranial lesions. Visual erode response to classic pattern associated with the hepatic encephalopathy. A 4-pronged approach to the management of hepatic encephalopathy is recommended, that is initiation of the care of the patient without consciousness. As long as the patient arrives to you, then start the basic care. Then alternative causes of the altered mental status should be sought and treated. Identification of the precipitating factors and their corrections, and the commencement of the empirical hepatic encephalopathy treatment. Treatment includes non-absorbable disaccharide, that is lactulose. Lactulose basically removes ammonia from the gut so that further ammonia cannot be absorbed from the gut. Rifaximin is an effective add-on therapy. It is a non-absorbable antibiotic that kills the bacteria which are producing ammonia into the body. oral branch and amino acids and IV and ornithine and aspartate. Basically, the whole concept behind this treatment is decrease production of ammonia. And the ammonia is the basic source. There are many others toxins, but ammonia is the main source. Once the episodes of the hepatic encephalopathy occurs, and the prevention should be done with the lactose and the reflex. Hepatocellular carcinoma, this is the more deadly complication of the decompensating event. The most common primary liver cancer, patient into the right upper quadrant pain, loss of appetite, feeling of fullness, weight loss, weakness, or deep fatigue, nausea, vomiting, jaundice. The major risk factor includes chronic alcohol consumption, hepatitis B and C, non-alcoholic fatty liver disease. Less common causes include Wilson disease, hereditary hemochromatosis, alpha-1 antitrypsin deficiency, primary biliary cirrhosis, and autoimmune hepatitis. Diagnostic investigation in HCC includes ultrasound, alpha-fetoprotein. These should be repeated every 6 months. CT scan, abdomen, triphasic study. This is very diagnostic. Triphasic study means basically study is being done in the 3 phases: arterial phase, venous phase, and the navate phase. MRI abdomen, and if there is diagnostic dilemma, then the liver biopsy. Associated investigations include workup for the child class, which include abdomen, abdomen rating, and workup for the cause of HCC. Management is slight complex. It depends on the BCLC staging. BCLC is the Barcelona classification of the liver cancer. On the early stage, we have the different treatment. This requires HCC into the 5 stages from stage 0 to stage 3. Stage 0 is the very early stage. Its treatment includes resection, and stage A is the early stage. Its treatment includes liver transplantation or radiofrequency ablation. Stage B is the I will show the picture. Stage B is the intermediate stage, that is multinodular phase. Stage C is the advanced stage. There is the portal invasion and the vascular involvement. Then we get the sorafenib, which is the hepatic agent, and the terminal stage B is the treatment is the breast supported care. We cannot do for the primary disease, but we do only breast support. This is the Barcelona staging, and the further treatment stage 0, having single lesion, small lesion. Stage A, multiple lesions, small lesion. Stage B, multinodular bilateral lesions. Stage C, there is the portal invasion, and stage D is the basically advanced stage.